Hi everybody, welcome to yet another QI Talk Time. Thank you very much for giving up your lunchtime to join us today. So today we've got Paul Rafferty with us, who's going to be speaking to Winning Hearts and Minds, a QI project story. Sorry, we're just having a little bit of a technical difficulty here with the slides. Nice. So Paul is an experienced facilitator in improvement, and he's a part of the faculty in the RCPI HSC QID diploma, and he's also worked on the TPOT training course. He's assisted both private and public hospitals to have issues like patient safety, experience, outcomes, cost, access, and flow. He's also led the reorganisation and consolidation of clinical directorates in a number of hospitals, and worked in the national clinical programs with Dr. Barry Wright back when they were set up a number of years ago. Paul established Clinic Effect, excuse me if I'm pronouncing that wrong, Clinic Effect Consulting in April 2015, which focuses on specific clinic pathways, services to achieve what they are intended to achieve in terms of patient outcome, safety, experience, access, flow, and cost. So we're delighted to have Paul with us today to speak to us. So just a few quick tips on the actual Webex function. So just to keep it interactive as possible, there is a chat box function. So if anyone has any comments or questions or ideas or anything that they want to ask Paul, you can type in that chat box. So just tick it blue and make sure that you select all participants so that everybody can see the chat throughout the webinar. We'll have some time at the end for any comments or questions, so do please type them in. For the sound, it is best to dial in, but if you are listening through your computer, hopefully it's a good enough sound quality for you as well. And if anyone is on Twitter, we would be delighted if you'd tweet today during the webinar at QI Talk Time. So without further ado, I'm going to hand over to Paul.
Thanks, Roisin. Thanks everybody for this opportunity. My objective today is to share with you a project where we used a number of QI tools, and my real objective is to show you how you can use these tools not just to win people's minds but their hearts as well. And hopefully in doing so I'll be able to explain to you how you can avoid some of the pitfalls when you use these tools. For those who've been on the diploma in the RCPI, they know that my mantra is you get 95% of the marks for winning people's hearts and 5% of the mark for winning their minds. A lot of people are very good at identifying what the problem is and what the solution is. The challenge is, can you persuade other people to buy into that solution you've identified? And how we use these tools can either help you win hearts, or in fact, if we use them incorrectly, we can lose people along the journey. So a bit like Jeff here, I'm going to try and show you through the project ways to avoid the pitfalls when using some of these tools. The project we're going to look at is improvement in an echo service in an acute hospital, and I'd like to thank the clinical director who is responsible for this service for giving me permission to share this project. So a little bit of background about that echo service. There was, at the time, they had 3 machines, which 2 were operational. On average, there'd be 2 technicians available to support the service, one of whom was fully trained and another one who needed some supervision in terms of oversight in what they were doing. The opening hours of the service were 8:30 to 16:30, varied sometimes Monday to Friday, because sometimes they had in-service training. In parallel to that, the biggest demand for the service came from cardiology clinics, and there was one of these happening every morning and afternoon, Monday to Friday. So what were the challenges they faced? At the time, there was about 800 patients who were referred by multiple specialties to the echo service. If you're a non-cardiology patient being referred from an outpatient setting, your wait time was anything between 40 and 50 days to get an echo, which obviously has risks in terms of the delay in getting a test for a patient. In addition, there was some anecdotal evidence that some of the delayed discharges from the hospital were due to singularly people waiting for echo tests. And also, when we looked at other patient pathways, we could see that echoes did have a contribution to the flow in those, access to echoes did have a contribution to the flow in those pathways. So that was the background, and for those familiar with QI methodologies, the first thing we would have done was agreed an aim statement. And so for this project, the aim statement was to try and increase the echo service utilization from X to Y. Why do we say X to Y? Well, when we started the project, we weren't quite sure what the real capacity of the service was. And so in order to make a smart aim statement, we put a placeholder, and from X was what was the current utilization of the service, to Y was where do we want to go. And we wanted to do that within a defined time period for all inpatient and outpatient referrals. So our aim statement ticked the smart box, even though we were just identifying things at the present in terms of X and Y. But that really wasn't the full story. The real story about this service was about the team. So the echo team, morale at that time was pretty low. The real issue was that the echo team would come in the morning and they would go into the testing room, and they would basically stay there all day. There was no windows. And the reason they were there all day is because demand was unpredictable. They weren't quite sure when patients would arrive. So there had to be somebody there all the time, and the team would have their lunch in the room. So the team was really caught between a rock and a hard place. On one side, they had a group of cardiologists who were running clinics and needed their patients turned around immediately. And on the other side, they had every other specialty trying to access their service. And they were doing this with an unclear rule set and an unclear process. So when we presented our aim statement, which ticked all the methodology and training boxes in terms of it being smart, when they looked at that aim statement, they really needed it like a hole in the head. Because when they saw the statement, they said, well, this looks like more work, and we're already at the max. So in terms of winning people's hearts, my first lesson was, in addition to doing an aim statement, you need to make sure that you're addressing the staff's pain. And so whenever I now do projects like this, one of the very first slides that I do is I indicate what the issues are with the process, but also what the staff pain is. Because I know in order to deliver improvement, I need to have their support. And if I'm not doing something to help them deal with their pain they experience on a day-to-day basis, then I won't be successful. So yes, to win minds, you need to have a clear, smart statement. But the lesson I've learned was to win hearts, you need to have an aim statement or talk about your project in the context of the pain staff are experiencing. Because if they don't feel there's something in it for them, then irrespective of how smart your aim statement is, why should they engage? We've seen this in other areas I've looked at, such as theatre on time starts. Yes, we want to start theatres on time in order to ensure we get as many patients safely through it. But really, the motivation for starting on time and finishing on time is so that staff can get home on time to look after their family and have a life outside work. So that was the lesson, which is have a clear aim statement, but also to win hearts, make sure your aim statement speaks to what the pain staff are experiencing. So we kicked off our project, and for those who are familiar with some of the tools of quality improvement, this slide might be familiar to you, which is we mapped the process. We tried to understand the end-to-end flow for cardiology patients accessing and going through the echo service. The lines, the swim lanes, as we call them, indicate each of the players in the patient journey and what the tasks they do are. And at a high level, we can see where the sources of referrals came from, how referrals were triaged and prioritized, how staff were rostered to the echo service, how patients were scheduled, how a patient was called, and the process of doing the test and reporting it. So the process map gave us a clear view of all the steps. But the risk with using a tool like process mapping is we obsess about the map and making it perfect and look well, when we in fact forget what the real purpose of process mapping is. The purpose of process mapping is to facilitate a conversation between a multidisciplinary team. the output of process mapping is not a map. The output is that a group of people who work together have a focused conversation and identify the issues and opportunities for improvement. So when people come to me with a beautiful process map, but not a list of issues, I say you've missed the trick. The trick is to use process mapping, use the tool to help make the team come together, to help foster and facilitate ownership of the end-to-end process and ownership of the improvement. So the most important skill in process mapping is not necessarily being an expert at process mapping, it's your ability to facilitate a multidisciplinary team. So yes, to appeal to people's minds and make them understand what the problem is, you need to map the process and identify the issues. But to win people's hearts is how you use that tool. If you facilitate people correctly, not only will you get a map, but you'll help to bring together a multidisciplinary team so they've got a clear view of each other's roles. So as I said, the key skill is facilitation, and the key output is the issues and not the flow chart itself. So having understood the flow, we then went into measurements. So the risk with measurement is that because of many of our systems are not integrated, there always tends to be an element of manual measurement. We're relying on colleagues to collect data first. The risk in doing that is that if we don't collect the right data correctly the first time, is we have to go back to colleagues who've already been kind enough to give us their time and ask them, you know what, we missed something, could you collect some more information for us? So what I've learned to do is, in collecting data, planning measurement is really key. This simple template is what I use to plan measurements. On the top left-hand side, you can see we identify what is the measure we want to collect. Critically, what's the operational definition? That's really important because, for example, one person's theatre on-time start may be different to another person's definition. So is on-time start when the patient gets into the theatre? Is it when knife goes to skin? Is it when the patient's anesthesia starts? So being really clear on the operational definition up front before you even collect data is really critical, because the risk is, having collected all the data and you present it, people start questioning your definition of how you've gone about collecting the data. How much data do we need to collect? Who collects it when we have to collect it? So planning measurement is key. So for our ECHO project, this was our measurement plan. Without going through the detail, what we did was said, what are the questions we're trying to answer and what data do we need to collect those? So our key questions was, how many echoes do we do a day? In other words, what's our current utilization? Where do referrals come from and how many do we receive? In other words, what's the demand? And how long does it take to do an echo? So we didn't collect any data until we were absolutely crystal clear what it was the questions we're trying to answer and what kind of data do we need. The other thing I've learned is that even before going to collect the data is to mock up how you're going to analyze the data in Excel beforehand. You might feel this is a little bit of overkill, but I found it saves a lot of time. So what you're looking at here is, once we understood what we're going to collect, we mocked it up in a spreadsheet and we put in dummy data. That meant we figured out exactly how we wanted the data given to us in order to create the illustrations and charts we have to have. We found by mocking things up beforehand, it saved an incredible amount of time. The risk is you collect the data and then you begin to try and figure out, well, how do we make this data talk? My advice is figure out what data you need to collect first, mock it up so that the next step, which is the template you give to staff, is structured so that they give you the data exactly how you need it. So here's the actual template the ECHO team would have used on a daily basis to collect data. On the left-hand side, you can see the different sources the patient is coming from, whether they were coming from a cardio clinic, inpatient OPD. The yellow is indicating referrals that were coming from inpatients. The slightly grayer to the right is referrals coming from outpatients. And then we're tracking for each patient the time they came in and out of the ECHO room and how long it took to report, who did it. In the top right-hand corner, you can see the number of WTs that are available. In the bottom left-hand corner, how many of these patients came from the cardio clinic and observation. Because we've gone to the trouble of being really clear on what questions we want to answer, and we'd mocked up how we wanted the data, it meant that we got the data exactly how we needed it. So the minute we got the data, we could begin to make it talk. So again, yes, it's very important to be clear about the questions you want to answer and plan what data you require to answer them. But in order to build trust amongst the team, what we did is we didn't tell the team what data we wanted. We facilitated the team in agreeing what the measures were to be. We created the model, and then we worked with the team to create the manual template to collect the data. So we didn't give them things. We worked with them, and they helped us shape it, and we understood what was useful to them and what was as least intrusive to their daily work to do that. The critical thing also I've learned is that if you're collecting data manually, is every day to touch base with the team who are collecting it. Have a little huddle over a cup of tea, or pop into the room where they're working, just to check that is the template working. And what I've learned is after the first 2 or 3 days, you realize the team have found a smarter way of collecting the data, and I adapted the template. The other thing is, on a daily basis, I show them the data so they understand how this data is being illustrated, and that helps build trust. So having got the data, we can begin to make it talk, and here's some of the graphs we created. This graph is indicating on a daily basis the source of referrals, whether it was from the clinic or OPD or inpatient. What you can see clearly is that if you're an OPD patient, there isn't necessarily an equitable distribution of slots. And that became one of the issues we needed to fix. The other thing is, and on the previous Webex, the guys talked about measurements, is we could illustrate over time how many echoes were being done. And you could see it was reasonably consistent. But there's 2 things I want to point out here, which I think are really crucial in relation to measurements that I've learned. The first one is the green line. The green line indicates the number of echoes that were done per WTE, per person available. Why is that important? It's important because with such high turnover of staff and issues in terms of staff availability, if you show total output of a team, in a way sometimes it's unfair because the number of people in the team varies on a day-to-day basis. So one of the things I've learned is that when you're looking at data over time, show what the total output is, but also try and show it in terms of the number of staff that were actually available. So we recognize, okay, we mightn't have got through as many patients as we expected, but the reason was we didn't have as much staff as we expected. And I find staff welcome that view in terms of for WTE view things. The other thing is that you notice on the graph that we measure not just the average number of echoes that were done today, but also the median number. So average you're probably familiar with. The median is what that means is that 50% of your patients lie either side of the median. So in this case, we had 18 echoes. But a better way of illustrating that is in the following graph. So first, to explain why median is important, if you look at this graph, imagine we're looking at the average length of stay. Along the horizontal axis, you can see days, how many days a patient was with us. On the vertical axis, you can see the number of patients. And that allows us to plot things like this. So, for example, in this study, 10 patients were with us for 5 days. Or over time, there was about 62 patients that were with us for 10 days. As we plot that data, we can join it up with a line, and this gives us a view of the variation. So some people are with us for less than 10 days, some people are with us for more than 10 days. So the average is A there, it's 10. So we're trying to, for example, reduce the variation in length of stay. So we set ourselves an aim. Let's say our aim is we think it is right for the patient, clinically appropriate, that they should be with us for no longer than 12 days. What the graph indicates then is that patients experiencing care outside that aim is our opportunity for improvement. So I'm going to show you another graph, and I'd like you to look at it closely. So this is the graph B. My question to you is, what has changed between A and B, and what has not changed between A and B? Think about that a second. Look at the 2 graphs. What has not changed between A and B? What's the same and what's different? Well, you may have spotted it. What has not changed is that the average is the exact same. The average for A and the average for B, the average length of stay is the exact same, 10 days. But what has changed is, if you look at B and follow the tail, you'll see a significant number of patients is now not with us for as long as compared to A. So what has happened is we reduced the variation in average length of stay without shifting the average. So the irony in a way is that the hospital system, a lot of our metrics is based on average, but average is actually a poor comparator between hospitals or between teams or between days. The enemy is variation, not average. Patients experience what they experience. They don't experience average. So to give you an example, further example to put some meat on that is if you look at this data set here. This is the average length of stay of stroke patients in a hospital. Along the bottom, you can see how long they were with us, some for 23 days, some for as long as 563 days. If you look at the first bar, the tall bar there, you can see that 628 patients were with us from 0 to 23 days. If you were to measure the average length of stay for this group of patients, you can see in the box above there, mean, which also is a word for average, the average length of stay was 30 days. But the median length of stay is 10 days. So if we were to say that this team's performance was an average length of stay of 30 days, it really isn't a fair picture. A better indicator of the effectiveness of this team to manage a patient's stay is 10 days. The reason the mean is not a good indicator is because most hospital data or clinical data is what we call skews. There's outliers. So you can see those patients, those small number of patients from 164, 108, 211 days, that small number of patients is skewing our average and pulling it out. So the average is penalizing us in a way for the length of stay of a number of patients. We need to understand why those patients are staying so long with us. But in order to engage a team, I've found that if you show them the mean and the median, so for this team, they're doing a pretty good job in managing the patients for 10 days. That's a good indicator of what they're doing, whereas to say that their average 30 days is almost penalizing them in a way. So again, in order to win people's minds, we have to talk about average, but in order to win people's hearts, we need to talk about medium and probably show the two together and understand how data becomes skewed by outliers. And that's what this slide is saying here. Yes, we need to measure variation over time, but things I've learned in order to win people's hearts is don't just look at the total output of a team, look at the output by WTE so that we understand when we were a down team, did the team still perform at a WTE level? Yes, measure average, but also measure medium in order to account for variation. The other thing that was interesting about this project is we looked for variation beyond the process itself, beyond the pathway itself. One of the things we discovered is that while there was 9.5 funded WT for this service, only one of the team was fully trained. One was trained and needed some supervision, and one was in training, with 6.5 not trained. So in a way, when people looked and said about this team, they said, well, you've got a full complement of staff. You've got 9.5. But what we discovered is that there was variation in the skill set. And so the message is, don't just look for variation in the process or the pathway. We need to look holistically at other reasons for variation. Look for causes for everywhere. Look at the skill, look at the culture, look at the leadership, etc. So with the data, we were able to begin to understand a little bit more what was going on. And this graph here, again, is showing you over time. The green line is the total time it took to do an echo test, which on average was about 26 minutes. And we looked at it from the median point of view and it was almost the exact same. So it was really consistent. The blue line is how long it took to do the test, i.e. how long the patient was on the table. and the red line is how long it took to do the report. So if you add the blue and red line together, it gives you the total length of time. Now we understand what the total length of time it takes to do an echo test is. With that information, we can begin to understand what our utilization is. So the workday was 8:30 to 16:30, which is 8 hours. But remember, we are about addressing the staff's pain. And because of the way this team was working in an unstructured process, and because they were having to take their lunch at their desk, we were very keen to make sure whatever solution we came up with ensured that they were able to take their lunch and ensure they were able to take their breaks in the morning and afternoon. So really, our available time for doing utilizing the system was 8 hours less the time for lunch breaks. 6 hours 30 is what you come up with. And we had 2 machines. So we basically had 13 hours worth of time to do patients echoes. So if you plot that on the graph on the side, the red line is the 13 hours. Remember, that red line is allowing for staff to take their breaks, which up to that point they weren't able to do. The blue line indicates how often we were actually testing patients for echoes. So the difference between the two gives you your utilization rate. So you can see the utilization was 49, 46 cents. So straight away we could see we weren't fully utilizing the service. Yet when we engaged the team, the morale was low. Their feeling was they were working all the hours God gave them, and there was pressure to get more resource. But this was a key lesson for me, which I've come across a good few times, which is that what people perceive as going on may not be actually what's going on, because they're viewing the world through, if you like, an emotional lens. They're judging things on how they're feeling. What was going on here, it wasn't demand that was hurting the team, it was the process. This team was caught between a rock and a hard place. There was unclear rule sets. They were getting pressure from cardiologists to turn around patients, and they were getting pressure from all other specialties, asking them why they weren't able to see their patients. So the emotional wear and tear of a poor process was what was wearing them down. It wasn't demand. And I've seen this in a lot of the pathways we've looked at, is when people say we're working at max, I've learned you need to look at the data and see, are we working at max, or is it poor process, poor team working that is making it feel harder than it should be? So the question was, what is our true capacity then? Well, using the same figures again, we've got 6 hours 30 worth of time. We know it now takes 26 minutes to do an echo. So if you divide 26 into 6 hours 30, for one machine we should be doing 15, for 2 machines doing 30. What we learned is that there's a clinical guideline that says an echo should not be taking less than 30 minutes. The view would be, if you're taking less than 30 minutes, they would question whether you're doing the echo effectively. So our rule then became 30 minutes. The important thing is to remember, in looking at this data and analyzing it, we did it with the team. This wasn't data we showed them, they helped us crunch the numbers. So was that 30 an attainable? Was it a smart aim? Was it achievable? Well, the team helped us, and they looked backwards, and they looked at historical data to see what was the trend when they had a full team. When they had 2 WTEs with 2 fully trained people, 1 training, you could hit those numbers. So the view was, yes, it's an attainable target under the assumption that we've got 2 fully trained staff and 1 who's in training. So again, you need to set measurable evidence-based targets, but to win people's hearts, you don't give them those targets. You work with them, you facilitate them, and get them to reach their conclusion about what the target should be. So having done the analysis, we revert, for those who are familiar with driver diagrams, I'll just explain a driver diagram here. On the left-hand side is our aim. We want to do 30 echoes. The primary drivers is, in order to deliver that, what must be critically in place? What must be present in order for us to deliver that? Well, we clearly need to have the machines available. We need to understand the level of demand. We need to be able to optimize the available time, but critically we need motivated staff, and those staff need effective leadership and management. These were the primary drivers. In our analysis, we began to see where our problems lied. If you look over the right-hand side, clearly a standout issue was the absence of scheduling, and that was something we needed to fix. To fix it, what we did is we introduced time slots of 30 minutes, and that meant that we could begin to schedule patients into slots rather than them randomly evolve. In order to win the hearts of the consultants who were in the cardiology clinics who were afraid that time slots might slow down the turnaround of patients in the clinics, we were able to demonstrate to them. On the left-hand side, we could see the actual time patients arrived from the clinic, and we showed them that by using time slots, there might be a slight delay in their turnaround time, but not one that would be significant or cause overrun in their clinics. So clearly, introducing scheduling was a key solution, but it wasn't the only solution. Because we've looked at variation holistically, we realized there was variation in the way we were training people, and so that needs to be addressed. It also helped us think about the type of people we were recruiting. We needed to recruit people with the right skills. So rather than recruiting 2 junior staff, we needed to recruit 1 skilled member of staff who could do things independently rather than being supervised. Other solutions that were important was our ability to control inappropriate demand. So we changed the way echoes were ordered that required people to indicate more clearly clinical indicators. In other words, a hurdle was put in front of them to make them really think, well, do you really need this echo? We need to motivate the staff, and the way we did that was making sure that they got their lunch breaks, their tea breaks, and they felt that their voice was being heard. In a way, the facilitation workshop around the process mapping brought the multidisciplinary team together, and it gave an opportunity for staff members to talk about the process to other colleagues of different professions, and that helped gender team and it helped their voice being heard. Critically, at the bottom, in order to sustain the change, we also had to look at how the operational management of the service worked and what data was the managers looking at in order to ensure improvement was sustained. So yes, we had solutions that was about practical things like scheduling, but we also had to have solutions that was about winning people's hearts. Without the two of them, we wouldn't sustain the improvement. The next step was to have a plan, and I won't go through it here, but we had a plan, and that plan was about not just implementing the change, but also who do we need to communicate in order to get their buy-in into these changes. One of the lessons I've learned from many of the projects we've done on the diploma is a good way of winning people's hearts is the use of cupcakes. There was an important lesson around this, which was one of the best projects I've seen on the diploma was about medication safety. And the project involved ensuring that when a pharmacist put notes on a patient chart, they had to be actioned within 24 hours. To do that, the person who did the project put large paper clips on top of each chart. So there was a visual clue to people that they had to action the notes in the chart. But what she also did is that if you picked up the paper clip, you could exchange it at the end of the week for cupcakes. So not only did she deliver 100% improvement on our baseline, she also made it fun. So making change fun is a key way of obviously winning their hearts and potentially worsening their cholesterol. So again, I think it's really important to have an implementation plan that includes your PDSA cycles and communication. And ideally, you need that plan to be trackable and have accountability for its deliverable. It's important when you're selling improvement that you sell the benefits of the improvement and not just the methodology. And don't be afraid to make the change fun. So what was the outcome? Well, the red columns here indicate prior to the improvements the number of echoes that were done by the team in terms of different types of sources, cardio clinic. With the team hitting the target, we shifted that up to 450. And remember, there was a third machine that was available but wasn't operational. And if you'd included that machine and made it operational, we would actually have had more capacity than we had demand. To make a personal point, I think this lesson for me is that until we applied the methodology or the tools, there was a lot of talk about the issue was we don't have enough people. We don't have enough resource. In fact, they've gone to the trouble of buying a third machine. But the issue was never about resource. It was never about machines. It was about the process and the teamwork. In fact, the third machine was probably not necessarily needed to be invested in. So just coming to the end, the trick with any change is sustainability. It's the holy grail of any change. And we don't have time today to go into detail. It might be something we'll come back to. But having gone to the trouble of engaging and winning people's hearts and minds, having gone to the trouble of putting in improvement, the trick is how do you sustain it? How do you transition from delivering project benefits to business as usual? And the risk is if you don't make that transition, the improvements begin to fade away and fail. And what you end up embedding is not improvement, but cynicism. So sustainability and how you do it is really, really important. There's lots of tips and techniques to doing that, but really one of the key things is what I recommend is to leave behind a dashboard of some shape or form. This was the dashboard we left behind for the ECHO team. The top graph is showing you the number against the target of echoes done on a daily basis. The middle graph is showing you the number of echoes done by each WTE against the target. And the bottom graph is showing you whether we had equitable distribution of slots between different sources of referrals. The real trick to a dashboard is governance. We did leave behind the dashboard, but the trick is who owns it. Who at a management level, at a clinical directorate level, at a cardiology lead level owns it. So it's great having a dashboard. It does have sustainability, but the key to sustainability is making sure somebody owns it and at some meeting it's reviewed. So in summary, my objective was to talk through a project and share with you how I've applied some of the tools that people are trained in QI, but really to show that it's not just about the application of the tools, it's how you use it. So in summary, I would say it's really important to have an aim statement, a smart aim statement. But what I've learned is you need to be talking upfront about the staff pain if you want to win their hearts. And there must be some aim in your project that's about addressing their pain, not necessarily just the organization's pain. Yes, it's important to illustrate and analyze the flow and use process mapping tools, but the thing to remember is process mapping is a tool to facilitate a conversation, and the purpose of that conversation is for a team collectively to identify issues and begin to own those issues. The objective of process mapping is not the map. That's a means to an end. Make sure you use objective data to avoid subjective analysis, but the thing about measurement is people are busy. They don't have that much time to be helpful to you in terms of gathering data. Make sure you know what data you want to collect. Make sure you've given them a very easy-to-use template that gives you the data in the right way. So planning measurement is key. You need to illustrate variation using run charts or control charts, but keep an eye on average and median. Keep an eye, if there's a difference between average and median, then you may have outliers. And the average may not be a true representation of the performance of a team or a process. Look for causes of variation beyond the process steps itself. Look at the skill mix of the team, look at the culture, look at the leadership. There's other reasons that cause variation that can't be explained using data. I think it's important to have an evidence-based target, but the key to target is that the team has developed it and it hasn't been given to them. Yes, you need to do PDSAs, but I do believe an element of project management is required in order to ensure you get delivery of change and try and make things fun. So on the diploma, in other words, many people learn different methodologies. There's lots of improvement religions, whether it's Lean Six Sigma, microsystems, the IHA methodology. All of them at their heart have these simple tool sets. The key to these tool sets is yes, you need to use them, yes, you need to know how to apply them, but how you engage people in their use, that's about winning people's hearts. If you use them rightly, these tools will help you win people's hearts. If you don't use them the right way, you could actually break people's hearts. So I hope that's been helpful, and there's some lessons for you to take away from that. I think Philip is going to say a few words. I see him walking towards me.
Thanks very much, Paul. That's great. I've been lurking in the background there. Great to see so many people online again, and the whole webinar process has been so well facilitated by Russia and Noemi as well. It's been, I think, a very effective tool really for communicating with people, and with far too much time is spent traveling to things, I think, and it's great that we can use modern technology and and deal with this very, very important topic. It seems to me, there is a lot of good work in the system, and you've seen it, and I see it all the time, and I think sometimes people feel they don't get a lot of credit for it, and part of that is because they don't measure it. If you don't measure something, I suppose, in the end of the day, we say it's good, we know it's good, it feels good, and people feel better after it. Things look better. But it's hard to convince people, isn't it? And I'm sure you've come across a lot of the time. People are willing to do the hard work of improving something, but they're not always willing to do the work of measuring it.
Yeah, I think measurement is key, but I think what I'm trying to sell is that don't collect the data and sort of measure in isolation and come back with the analysis. Always work with the team, work with them to agree what the measures are. As you're analyzing the data, show them first the analysis rather than showing somebody else, because people sometimes have a fear about how data is going to be used. So to win their hearts, the analysis will give insight to people. It would make people think about things, but you want to really win people's engagement in delivering the change. So in order to build that trust, the thing with data is to make sure you're working with the team to agree the measures, to make it as simple as possible for them to gather the data, make sure you gather the data right first time. So that means an onus is on the improver to think really clearly about what data they need to have, to mock things up beforehand, and to share the data as you're analyzing it rather than come and surprise people with the analysis. I think the other thing I've learned, Philip, is that people are so busy in the system. People are working so hard. And that, with issues in terms of staff coverage and something, the same group of people are being asked to do more and more and more. And when you begin to get worn down, you get tired, you begin to feel that, well, the issue is demand. There is too much demand. And I found the power of data is to begin to get them to realize, actually, in some cases, demand is not the problem. We don't actually need more resource. What we need is a better way of team working, a better way of managing the process. And we need to look at it in that lens. So data can be quite powerful in helping to shift people from that emotional state, their emotional view of what's happening, to getting to realize, actually, what you're feeling is not actually happening. The problem is not demand. The problem is how we work together.
I think the great thing about the presentation has been, as you say, to kind of highlight the hearts part of it, because I think the data world is populated by a lot of people who maybe don't really always get that. I think you're right also, Stan. I'd be interested to see what people think online. Data hasn't always been used in a very kind way, maybe, or even a very positive way. It's been used, you can use data to punish people. You can, and I think a lot of the way we use data nationally as well. If you look at our performance report, it's going to improve. We're working with the Business Intelligence Unit to try and improve it. But really, we display a lot of data in a way that's not very effective, it seems to me. I don't know if you've looked at the performance report recently or if people online have looked at it, but there's a lot of point-in-time data maybe compared with 1 year previously. It's totally aggregated on a national basis, so there's a lot of variation in it that you can't see. And it doesn't really tell us. It's hard to interpret, and I try and do a bit of a job of interpreting it for the leadership team, and I have to work hard at it. It's not easy. I think a lot of the people's experience locally of data is other people, like centrally, are demanding data from them, so they kind of hand over data. So this sense of people owning their own data seems to me to be pretty crucial as well.
It is. I think in some respects people are hungry for data, but data presented in a way that isn't blaming people for things, but gives them insight. So I think the work that Jennifer and people and the guys in your team are doing, trying to promote the use of control charts and run chart, I think at a senior level in the HSE is a really positive thing. I think in statistics, you need to have about 30 points of data in order to say what's happening is true. And as you say, we tend to look at things at a point in time as opposed to over time. And what we know from looking at data is that there's always variation, what we call common cause variation, and sometimes we overreact. there's a complete reaction to what is actually natural variation, and if we didn't do anything, it would correct itself. So it's important to look at data over time, make sure we've got a statistically correct amount of data to draw a conclusion. The data is presented in a way that engages people rather than turns them off. And we recognize the difference between common cause and special cause variation.
We probably need to invest a bit more in data as well, don't we, in terms of just capacity to collect all this data, because it's obviously, it's very hard to work without knowing where you're going, and if you're not measuring something, then you don't know whether you're improving or whether you're getting worse. But you've said yourself, it's a lot of work to gather this data, isn't it? I mean,
it is, but I would say that with the projects I've done, and speaking for folks that have been on the diploma, we've had a kind of considerable number of people on the diploma, is that data is out there. I think what we're beginning to learn is we just haven't necessarily been asking the right questions. And I know we've found in places like Cork, et cetera, that when you went to the IT guys and asked them, could you show the data this way, they can do it. It was just nobody asked them to see the data in that fashion before. So I think, Philip, you went to Intermountain, which I recommend the Intermountain case study to anybody, and that was about an organization and that, had pressure in terms of quality, pressure in terms of demand, and they needed to change things. And data was one of the tools they used, not the only one. But they invested in a big system, a lot of technology, and after they did that, they realized actually what we need to do is not just invest in technology, but invest in training people how to interpret data. Because if you have systems that give you data, but the people looking at it don't know how to question it, you don't get the value from the investment in technology. So it's about investing in technology, but investing in people and educating them how to use data.
And that's a bit of what we're trying to do, I guess, and what we're doing here today as well. The other thing I think they did in Intermountain, which I think we can consider, is trying to build kind of the data process into the work process, so it naturally flows out of it. One of the things they did there was they built a lot of the coding into the charts. So when you're clerking a patient to admit them, you inevitably code most of the key codes because the chart leads you down that road. And I think that's something that might make our jobs a little bit easier if we did a bit more of that. Any questions from online, or no? Maybe it's self-explanatory.
Lots of really good comments. It was just a sample on the presentation wall that it was really clear and a nice example of a QI project from the start right until the end. So lots of positive comments, but no questions for you.
I think just to finish on the point Philip was making there, sustainability is key.
Yeah.
So we've done lots of these projects where we've improved on-time starts with theatres, we've improved time for patients to get to theatre for the hip fracture, etc. But what we found is some of them begin to tail off, and the reason is we didn't make the transition from the project to business as usual. We didn't hand the project over to a clear governance group, whether it was a clinical director or a service lead, etc. And I think part of the issue there is that we need to look at how we coach people to run operational meetings. It's not natural to them to do that. The sustainability is about transferring the data, the improvement, to a clear individual or governance group, but it's critical that that person knows how to constantly look at this data and ask the right questions.
Very good. Great.
Okay, great. With that, we're going to. No, you're fine. With that, I'll stick my head in here and say thanks a million, Paul, for a really wonderful presentation. And our next QI Talk time is on Tuesday, the 20th of June, so I hope you can all join us. And it's with Greg Price's team, and we're hoping that we might have a Canadian speaker, actually, on tips on engaging patients, but that will be confirmed shortly. So thanks again for tuning in, and see you next time.